So this presentation is going to be led by Donogh. Donogh is one of our regional anesthesia fellows, and he's put this case together just really as a platform for discussing some issues related to thoracic epidural anesthesia. It is actually a case that was done at Toronto Western Hospital. Most of the broad strokes are real. Few things have been changed here and there. But we hope that it illustrates some of the issues that I think confront us all when we are thinking about performing thoracic epidural anesthesia as well as managing it. So without further ado, I'll let Donogh kick this off.
Thank you, Ki-Jinn. So the scenario one is, we just move the slide on. Okay, so this is, you are the staff anesthesiologist and the general surgery team consults you regarding a 25-year-old male with an epigastric hernia and recurrent episodes of incarceration. He's been added to tomorrow's list and you're covering it. And the following history is obtained. So the patient has Duchenne's muscular dystrophy. His pulmonary function tests reveal 15% of expected function with an FVC of 0.8 liters. He is dependent on continuous non-invasive positive pressure ventilation. And he furthermore has a dilated cardiomyopathy with an ejection fraction of 25%, although is hemodynamically stable currently. He's not anticoagulated, but he is on long-term steroids. He's minimally ambulant normally, being wheelchair dependent. On examination, he has moderate to severe scoliosis with a BMI of 22. He's never had any previous general anesthetic or regional anesthetic. And it's a very complicated case. You discuss it with colleagues, including his respiratory team. And the consensus is that he's a poor candidate for endotracheal intubation and would be at high risk for irreversible mechanical ventilation. So really the question is, what is your perioperative management plan and what specific details such as where you do it, what personnel, what adjuvant equipment would you consider? And secondly then, what is your post-operative analgesic plan? So we'll just put it out to the floor to see what people's thoughts are. Obviously we're pushing you a certain direction with it, but that was the actual case which we encountered. And obviously a difficult case, but in any case, we'll see what people think, what if anyone wants to chime in.
Well, I guess the first question would be, are we avoiding general anesthesia entirely? Does everybody agree that we should be pressing hard for a pure regional surgical anesthetic?
Yeah, I would think that would be a sensible plan, given that he's unlikely to be, it sounds like he'd be very high risk to be extubatable at the end.
Yep, I think that's probably reasonable. It looks like the surgery is of an extent that, it makes it feasible. It's not a sternum to, sternum to pubis kind of incision. So this looks like it's possible to be covered purely by regional anesthesia.
I guess starting off, you've already kind of touched on it, Donogh, already, but you do really need to consult some of the other specialties as well. So you need a bit more detail about his, you have said already, I guess, his respiratory function, what's his cardiac function like, what does the patient want as well, a frank conversation about the risks associated with the benefits and the risks of either regional or general anesthetic as well. So those would kind of be points I'd be thinking about, really.
Yeah, so in this case, the patient was in favor of surgery. His condition, the incarceration of his hernia has been something which is, quite difficult and perhaps life-threatening. So he's happy to proceed with surgery, and he, under no circumstances, wants to be have a likelihood of intubation with unable to extubate and have a long-term ICU plan with that. So really, from his point of view, he wants the surgery done on a regional technique.
And how high was the incision like planned, or what was the access? Because I think part of the, you know, one goals of care to start is really important to understand what you, if he wants it, and then even perioperative, how to manage it. But then I think the next step is more now planning around the anesthetic in terms of the surgical approach, the site of the incision, and then making sure he's optimized as best as you can from a respiratory and cardiac function, recognizing it's urgent surgery. I don't actually have the case pulled up because I'm having trouble with my computer, but I know that he's not, he's obstructed, but he's not unwell at this point. So I feel that here now, if you can, because once you start with the regional technique, the level that you go as well is still going to have intraoperative implications for his respiratory function. So I think this is where it's really important to plan with the surgical team to make sure that you guys are on the same page and recognize the limitations of what you can do and what they can do.
Those are great points, Sharon. So this chap it's sort of semi-elective. You know, he has episodes where of sort of recurrent incarcerations that resolve, but really they need to close the hernia so that he doesn't get an incarceration that proceeds to strangulation at some point. In terms of cardiorespiratory status, he is unfortunately as good as he's going to get. I mean, this is a chap who has a chronic, eventually terminal kind of illness. So what we see is essentially what we get. If I can remember the details correctly, I do believe the incision was in the sort of supraumbilical midline area. So let's call it, you know, the T7, T8 kind of area. That we would need to be covering, probably a couple more dermatomes on each side. Well,
I don't mean to derail the conversation either. It's just interesting.
No
Rampum recently just published, they had 44 patients in an RCT that they did VATS procedures on. So like I think, and the reason, the indication was because I don't know if we were going to talk about this or not, but the indication for doing this was one, to obviously have the lung biopsy, but also the inclusion criteria were patients who had severe pulmonary hypertension. So it's interesting because obviously we can do this, and I think it's feasible to do it, especially if you're telling me, you know, he's as good as he's going to get. Then it's just making sure that intraoperatively you've kind of planned for ABC, and then talk to him about, you know, if he does decompensate intraoperatively, what does he want you to do from a respiratory point of view, whether that's intubate and then, you know, minimal ventilation, optimize everything and try to extubate him as quickly as possible to a one-way extubation.
yeah, thanks for bringing that up. I think it's always good that you have to plan for when things don't go well, right? Hope for the best and plan for the worst. So there should be a backup plan if, for any reason, the regional technique doesn't succeed, or there's intraoperative issues with inadequate anesthesia. And, you know, that begs the question too, when you do kind of launch into your regional anesthetic technique and you're struggling, right? How long do you struggle for if it sort of gets technically difficult? And you know, that's one of the things we hope we'll talk about as we get down the road in this scenario. But let's just, why don't we talk about the kind of regional anesthetic techniques that are available? So clearly this session has been titled Thoracic Epidural. Are there any other regional techniques that anybody else would consider ahead of an epidural? And if not, Donogh, why don't you list some of them and put out your opinion on sort of the pros and cons of them?
I mean, the epidural obviously gives you the, you know, with a sufficient volume and dose of local anesthetic, gives you you know, an excellent operating conditions. The truncal blocks, there's, you know, there's very little, I think, evidence out there for truncal blocks as surgical anesthesia for anything other than very small incisions. And the problem there being if a larger incision was required intraoperatively, that your truncal block or your local anesthetic infiltration would not be sufficient. So I think in this case, I think if we are able to provide an approach which, if it's working effectively, will provide excellent and suitable conditions, I think that has to be your plan A. I think then plan B is your considerations are, if you're unable to complete your plan A, your thoracic epidural, despite a number of attempts due to the patient's unfavorable anatomy, at that stage, do you go for another regional technique, or do you suggest that it's failed and you need to take the risk of intubating? I think that's the main consideration as I would see it. Maybe
what was the duration of the case? Like from a surgical and a technical point of view, what was involved, and the duration that they anticipated? Because it sounds like this young gentleman was it was a chronic issue that what he was managing up until this point, but it just needed a definitive plan because it was becoming too frequent and problematic. Is that a correct assumption?
Yeah, that's correct. I think the surgeons expected it to be, relatively quick, within maybe 90 minutes. They said that they would need to do a mini laparotomy, like a midline incision of, I think 6 centimeters is what we said was the incision they ended up doing. But obviously pre-op, you don't know that for sure. But they suggested a supraumbilical midline incision as their approach.
And he wasn't obstructed at the time, right? Like he wasn't a full.
He wasn't obstructed at the time of surgery, no. So there was an opportunity to plan it, I suppose. It wasn't being done emergently right away. So there was an opportunity to plan, what technique and what personnel, etc. you would choose to go about it.
Mm-hmm. Because I see Josh there. Hi, Josh. Because at Sinai, and I think Josh mentioned it, at least Ki, I don't know if everyone got the email, but like we often do midline laparotomies for hysterectomies in percreta. So they're pregnant women who need to have a hysterectomy perioperatively. So we deliver the baby and then we do the hysterectomy typically. All with the plan of it being under epidural, sometimes we have to convert intraoperatively. So it actually is quite a feasible plan with a good surgical tech, like favorable surgical conditions, and a well thought out plan ahead. I mean, I guess you can also do it with like a spinal, because you can cover, like, again, we do lots of OB, you can cover with like a heavy bupivacaine and then just supplement to support his oxygenation intraoperatively, since he isn't actually a full stomach. So with like OptiFlow or something to just help with his respiratory function, just to get through the operative time, which is not a big operative time.
Yeah, I think spinal is something I guess which could be considered, but we in this case we thought obviously if we could manage a thoracic epidural, that would be more favorable, particularly in view of the distribution of the surgery. As Ki-Jinn said, kind of T sort of 7, 8, 9.
I think what we'd be concerned about in this case is the sympathetic blockade that would result from having to push the spinal up that high, given that he's also got this cardiomyopathy. And so, this issue always arises, right? Especially in exam scenarios. So do you go with a carefully titrated epidural? Everybody steers away from spinals because, in conditions with fixed cardiac outputs, you get this big drop in SVR. I think that's perhaps a little bit overstated in some scenarios, but here, I don't know. Here, I'd probably be a little bit leery of going with a high spinal, just because I'd be worried about the hemodynamic consequences of that.
What was his right ventricular function though? Because the cardiomyopathy in and of itself, like obviously he's got some bad right heart function. I don't see.
No, and you know what, Sharon, we don't have the full details of the case, but it was significant enough that all I can tell you was significant enough that was pushed off the side. But let me ask you something. You mentioned that, you know, your epidurals, sometimes you have to convert and sometimes you don't. What has been your and Josh's experience with the things that go wrong or the things that determine why the epidural doesn't work when you try and use it for surgical?
Usually we don't convert because of the epidural. It's because of hemodynamic instability if they get very bloody. Depends on how well the procreta is controlled, you know, the hysterectomy. So usually the epidural is well tested both with either, you know, Tsui test, waveform, lidocaine, and usually a combination of them. And then we really, for the most part, get through about a 3-4 hour procedure with rarely having to convert. And usually when we do convert, it's because of excessive bleeding, the baby's already been delivered, and it's, you know, controlling the airway once you're doing a coda mega is pretty difficult. So when it gets that, like that, we usually convert.
How do you dose the epidural? So what would be a typical loading dose? And then how would you decide when it needs topping up and what would you use?
So that's a good question. And the practice actually varies. Usually everybody loads it with lidocaine 2% with the epi. The average dose I find is around 15 mils. Sometimes 10 mils is enough. We test it with ice so we get a good sense of the dermatome coverage. And then most people end up at some point about, you know, 30 to 60 minutes in, once the baby's been delivered and the patient's stable, switching to bupivacaine 0.5%. But some people would still intermittently give lidocaine 2% instead. So it's a little bit of a variable practice, but most people still bolus instead of retinal infusion.
So is that empirical in terms of the timing of the boluses? Kind of like by feel?
Yeah, well, sometimes you would see the heart rate, you know, like some kind of hemodynamic changes, but rarely. Sometimes the patients themselves, you just get feedback from the patients, like, how are you doing? Are you feeling more pressure, less pressure? Like you really try and see, you know, the early onset, offset of the block. And if the patient starts complaining at some point, you would rebolus it. But most of us were around 60 minutes, just start giving empirically, like you suggested.
The other like consideration too is again, like surgically what's happening, because, you know, some procretas go really well and they're easy to control the bleeding and then do the hysterectomy, and others are much more technically challenging depending on where the infiltration of the vessels are. So like, again, from my experience, we usually end up intubating more because of hemodynamics, not because we're unable to do the planned surgery. It's usually they're a codomega. And the surgeons like communicate this pretty quickly when they realize it's going to be harder. Like the goal is get baby out and then make a more stable plan for mom for the hysterectomy.
Right. So basically what you guys are saying is that once you have your epidural in the right place, ensuring adequate anesthesia usually isn't a big issue.
I don't think it's, I like in the time that I've been doing them, it hasn't been an issue. And I think from speaking to our senior colleagues, they rarely need to convert because the epidurals failed you.
I think more often there was challenges with actually getting a well-sustained block with epidural catheter using a CSE. Because initially you got a great block, and then because the catheter is so low, it's in the lumbar space, to maintain a high enough block, they had, not often, but they sometimes would have cases where there was a patchy block. So this way, if you just go straight to the, you know, T12, T11, or T12L1 epidural space, you test the block, you're happy with it, you're willing to proceed, there's less likelihood of you actually needing to convert. So initially I thought CSE would be an easier option, but as I saw other people's practice, I do agree that a low thoracic epidural actually is more reliable in this case.
So that's an interesting, there's lots of interesting specifics here, which I think are quite important to discuss. And I'd like to take the opportunity here. So suppose in this case, we are talking about something that needs supraumbilical coverage. So T7, T8, T9, would you still, so the first question is, would you still put in the epidural at a low thoracic space like T10 or T11 and then expect to thread the catheter tip up? And then related to that, I think you mentioned briefly that you would used the Tsui test, which would obviously be a confirmation where the tip is actually lying. But if people weren't using the Tsui test, right, how confident can we be that the catheter tip has gone to the appropriate spinal level? And would it be a better option then to insert at a level that's more congruent with your surgical incision, recognizing that the spaces might be narrower and it might be technically more challenging?
What if looking at this case and the scoliosis, I would first of all decide my level based on not only the surgical incision, but what the ultrasound shows me of the more favorable space for the insertion, because depends how bad the scoliosis, but there might be an area like T7-8 might be easier than T9-10, or, you know, so that I think should be a factor. And to confirm which level you're at, I would just use ultrasound to scan all the way down and see which level. In order to confirm, nowadays I've switched to the transduction waveform like DQ Trend published. I find it's very sensitive and specific at the thoracic level. And it's actually easier to do when you're teaching trainees because you can do it in real time through either the catheter or the needle. And unlike the Tsui test, you can continue to test if you need intermittently. Let's say you're checking post-op if the catheter is being dislodged, whereas a Tsui test, you cannot do stimulation once you've given local.
So just so everybody knows what Josh is talking about, he's talking about waveform analysis where you essentially connect an arterial line type tubing and you transduce a waveform. And if your catheter is in the epidural space, you should get a pulsatile type waveform. Have I got that right, Josh?
Yeah, and I find, I heard him first talk about it at CS a few years ago, and me and Christian Erzola tried it. And I think at this point we've converted probably most of our colleagues at this site, and we do it routinely. It's cheap, it's effective. You can do it in PACU, you can do it in the OR. You don't need to go find the Tsui kit, which always gets lost. So, yeah.
So do you use it to confirm entry into the space initially with the needle, or do you only connect it once you've threaded the catheter?
If I'm with a trainee who's just learning thoracic epidurals, I will do it through the needle. If it's me and it felt good, I would thread a catheter and then just transduce the catheter. It's a little bit more dampened because it's a 22 gauge catheter versus a 17 gauge needle. But if it's in the right space, you should always see a waveform. The one caveat is you need to build a pressure column. If you haven't put enough saline or whatever fluid in, like lidocaine, you will probably get a false negative. So you got to know how to actually perform the test.
Does that mean you're committing to loss of resistance by saline?
Usually, yes, yeah, and that's always been my preference, so it's not an issue. But usually,
it might be a consideration to people who are used to using air, right?
You can still use air. You just have to fill the column with saline afterwards. You can still do air though.
Great, but unlike the Tsui test, it doesn't tell you necessarily where the catheter tip might actually be lying, right?
That was my point. That it doesn't. It just tells you that you're in the right space, but you won't know which direction the catheter has actually gone.
Do you think that in this day and age, we need to be using these ancillary adjuncts to tell us, you know, that this loss of resistance is a accurate loss of resistance and that we're actually putting it in?
Your case 3, I think, is an example of that.
Yep. Yeah.
Yeah. I mean, I'll tell you, when this case was actually done, because this chap was so challenging. Essentially, he was bedbound. The insertion conditions were less than ideal. He had this scoliosis. He had a lot of mobile tissue on his back. He was, it was difficult. And if memory serves me correctly, he, you know, it was placed, thought there was a lot of resistance, the catheter was threaded, and the way the catheter was kind of tested was by injecting lidocaine 2%. So coming back to your question about, you know, initiating the block, in your experience, how long does it take for a block to set up if the catheter is in the right place and you've injected, I don't know, 5-6 mils of 2% lidocaine?
To be honest,
When would you declare that it's not in the right place?
most of our, like when we're usually doing these cases, the epidural is the first thing to go in, and then you do all your other stuff, and you start loading your epidural early. So then you get your second large bore IV, you do your arterial line, the surgeons are scanning for baby. So this is one of those examples, at least in my experience, where the epidural is the first thing, and then all the time to get the rest of the OR ready is really the time to get the epidural prep to ensure that it is an adequate surgical block. Like you can't rush this. It takes the time, and that's why you get it up front, and then you use all of the other prep time to make sure that your epidural is effective for what you want it to do.
Also, this is a patient where I would not give a test dose of lidocaine, because what if this is somehow intrathecal, you would have hemodynamic collapse. Not likely, but I think our practice with labor patients with cardiac lesions, like fixed cardiac output, is not to test with lidocaine because of exactly this scenario.
Mm-hmm. So what you're left with then is basically waveform analysis or Tsui tests.
Correct. Like you could still give lidocaine, but I would be much more slow. I would titrate, give 1 or 2 cc's at first to watch for the hemodynamic response, and then probably, this is a carefully titrated epidural, like you said yourself, so yeah.
Ki, I have a question for you actually, because I feel like you were trying to lead the group into a discussion of seeing what the other options possibly could be. And now this is, from my abbreviated compared to your experience, I just find the truncal blocks and I know that you guys published an ESP for, I think it was like gastric surgery or something.
It was bariatric surgery, yeah.
Yeah, I never find I mean, if you have a motivated patient, then that is already one factor to to be successful in this. But I've just not found that the truncal blocks are effective enough to get a surgical block. And maybe, maybe I'm loading them, or maybe you have some pearls that can make it more effective. But that's when you were asking the question, I'm like, other than epidural, I really didn't feel like there was much. I gave you this final one. I feel like you were searching for something. But
I would agree. I think truncal blocks, the variability is just so much that I wouldn't count on it for a surgical anesthetic block. I mean, you've got all these case reports out there, but to be able to be confident that you are going to get it is difficult. I mean, they're all indirect blocks. And then the other issue here is that a chap like this, he was, quite small, quite hectic, so you're limited in mass and volume. And what you don't want to do is be squirting in lots of local here, and then that ties your hands with further techniques down the road, right? Because you're already now into local anesthetic systemic toxicity territory. So whatever technique I think you go with, you should be very, very confident it's going to give you the conditions that you want. And I would agree that I think truncal blocks most of the time are going to be, and truncal plane blocks, I should say, for most of the time are not going to be reliable enough for surgical anesthesia. A thoracic paravertebral, on the other hand, might be bilateral thoracic paravertebrals might be a different issue.
The one thing about doing that is if you failed at doing a thoracic epidural due to the anatomy, you might have a hard time with bilateral thoracic paravertebrals as well. Like if he's cachectic, I've tried doing like end-stage COPD, doing mastectomy under a paravertebral, and everything is so, the pleura and the costotramus ligament, it's not as easy.
And if you got a complication, it would probably be devastating at that moment.
Like a pneumo, yeah.
Yeah.
So I'll tell you now that this what actually happened in real life was the first epidural went in, and it didn't appear to be working based on the fact that he didn't develop a block, and it was eventually repeated. At the Western, our epidural workload is pretty low, and as such, we've never embraced or had the opportunity to embrace things like waveform analysis, or on a routine basis, the Tsui test. The problem with the Tsui test is you either need a specialized bit of kit, or to be able to stimulate an epidural catheter. Or I have seen, as I said, in other places where they have used a peripheral nerve stimulating kit and actually place a peripheral nerve catheter as the epidural catheter, because that usually has inbuilt nerve stimulating hardware technology into it. At Sinai or anywhere else, is anybody using the Tsui tests commonly?
A few people still. It's sometimes if I'm, it's a really high stakes epidural, I may just do both. Also for the teaching experience to show the resident there's different ways. But we have a kit. It gets lost sometimes, like you said. You need the Johans adapter, so it's a lure lock connector that has an electrode on it. So because we don't have, like you said, a nerve stimulating epidural. So to send the current in, you need that adapter, and then to close the circuit, you need a sticker on the patient.
To be honest too, it's one of these techniques that when we do them very frequently at Sinai, and it takes 2 minutes. When you're skilled and adept and you do it frequently enough, it doesn't, like the AAs know how to set it up. It really doesn't add very much time. Like I had a high stake epidural actually this week, and the fellow had perfect loss of resistance. I even checked it because it was such a high stakes epidural, and then we did a Tsui test and it failed. So, and then it delayed us by 5 minutes to just reinsert it. So I think that it's one of those things that it's an ancillary test that if you're well practiced in it, that it doesn't actually add much time. And I think to Josh's point as well now, adding the, looking at the waveform, doing it, like our AAs are now becoming so skilled at it that I don't know. Either of those tests adds 2 to 5 minutes to our epidural time.
That's excellent, and thanks for bringing that up, because obviously, you have to also trust that test enough to say, well, we're going to take this out and reinsert it again. Do you know why the initial loss of resistance felt so good, but yet was in the right place? Where do you think it had gone instead?
I don't know. So the fellow had actually done it, and I was watching him do it. And it's one of those things that when you actually do it yourself, that you are more confident saying, yes, it's in the right space. So when I watched him do it, it wasn't a crisp loss of resistance. And then I ended up redoing it, and it wasn't maybe like a hard black and white loss of resistance, but I just from a tactile feel, I knew it felt right. So with the fellow, actually, it just didn't look like a crisp loss. So we did the Tsui test, and that didn't show anything. And then we did the waveform using the epidural. And once I'd done both of them, I was like, okay, it's just not in. Let's just redo it. So I think that this is like, I know we'll get to case 3, but this is also to that point. It's like when you start having trainees, you know, there's so much value in you actually doing it yourself that you can't always, because the loss of resistance when I did it felt fine, but it was everything leading up to that I wasn't sure about.
I agree. I think this is one of the issues with regional. There's still a fair bit of art to it, right? And things either you just know that they're right or they're wrong, but the question becomes how to train people up to that level. Okay.
Can I actually just make one more comment? Did anyone read the VATS article? I see Dr. Slinger's on the chat as well. Did anyone read the article about the thoracoscopy for the VATS using epidurals? It was in Rampum, I think, in April or March.
I don't recall it off the top of my head, Sharon. I'm sorry.
Yeah, no. So they were doing it though. They were doing like a VATS where they were actually insufflating or minimal insufflation. They were able to do the resection doing that. So I don't know. It seems promising that maybe we can do more.
I don't know if you can hear me.
Yes, we can. Yeah.
So doing thoracic surgery with regional anesthesia is not new. I can remember Sandy Williams, who was a resident, published one in the late 80s from Toronto Western, a case with a bronchopleural fistula. So it can be done. I don't know if I have read the exact article that you're talking about, but I've seen lots of articles. So yeah, you can do it. Very, very doable if you have a good reason.
Have you done lots, Dr. Slinger? Have you done any? Like, have you?
Oh gosh, I'm trying to think. Have we done a case with just just with an epidural, I can't personally remember doing one. But, you know, a bronchopleural fistula or something, you know, you can make an excellent case for it in some cases. Some cases, I think it's just what people are into doing. You know, a lot of, I see more and more VATs being done with spontaneous ventilation, with or without an epidural, you know, with an LMA or awake or, I don't know if it's really a coming trend or if it's just a few centers are enthusiasts. So I have to say it's certainly doable.
But not for this guy though. He's got problem breathing already. Give him a sucking chest wound, he wouldn't be able to breathe.
Oh, not this guy. No, I'm not talking about this patient. I'm talking about just other patients in general.
In fact, I was thinking about the thoracic epidural made for this guy. You can take off some of his intercostal, he may have problem breathing as well. Obviously, this didn't happen, but it was one of the consideration. Because his main problem is muscular problem.
Yeah, I think you're right. You're right there. That's why we did talk about the fact that your neuraxial techniques may actually, you have to bear in mind that they can have impact on respiratory function as well.
It's Emil Pesca here from Sunnybrook. I want to suggest something controversial, and I'd like to sort of get people's experience and opinion. I'm part of a Facebook group called Regional Anesthesia, and there's a gentleman there that constantly does thoracic intrathecal catheters, and says he's never had a complication. I was wondering if anyone's got any thoughts. I mean, it's obviously outside the box. Has anyone got thoughts or experience on doing thoracic intrathecal catheters for surgical anesthesia?
So that's pretty extreme. I will say that thoracic spinals are done, and Simone Schiavo, who's one of our Italian fellows, has actually just mentioned on the chat about the fact that one of his the center where he used to work is doing it, and it's also a technique that's been around for a while. It's been described, it's been done. Apparently the thoracic intrathecal space is actually a lot more roomy than even the lumbar space in terms of entry, so it's not as fraught a technique as possible. I gotta say, I had not heard of having an intrathecal catheter place, which would sound even more fraught than a single shot spinal. But I guess anything is possible.
I think that the guy who does it is from an Italian center. I'm not exactly sure which one, but it's something it seems that he does very frequently. And I think, at least in my experience, in my training, it was a big no-no, but certainly seems to have been described,
Yeah, that guy is Dr. Starnari from an Italian center in Ancona. Actually, it's a geriatric center. They do not have any ICU. And so they were refusing at the beginning a lot of surgery, a lot of patients, and then they were starting with this regional intrathecal single shot first, and then with a kit called Spinolong, they started doing intrathecal catheters from T7 to T10, depending on the kind and the type of surgery. And I went there a couple of times to learn the technique and try basically it. It is absolutely, honestly amazing. I didn't believe it. To me, it was absolutely crazy. I saw a couple of gastrectomies. We did in our center a couple of gastrectomies with an intrathecal catheter, and you can literally titrate the local anesthesia that you're giving. You start with like 2.5 milligrams of bupivacaine, and then you can add 2.5 more. And usually we end up starting the case after 7.5. And hemodynamically, patients are extremely stable with minimal requirement of vasopressor, like 0.02 of norepi. And even the analgesia, they use even the intrathecal catheter for analgesia post-op, and it worked absolutely beautifully.
Would you say it was technically challenging to perform or master? And then the second question is, what was the rate of posterior puncture headache afterwards?
As far as I know, they didn't really have any headache, at least that's what they said. Actually, they published an article in Minerva, an Italian anesthesia journal, about the complication. They reported neurological complication about around 15%, but they were all delirium, TIA, maybe related more to the patient than the technique itself, obviously. Technically, I found it particularly difficult at the beginning, probably because of the inexperience. But then we did basically, I personally did 5 or 6 in total. Like at the 5th, I was pretty much more comfortable with the kit itself and with even the personnel that is assisting you. It's quite scary. That's the point, because we were taught that spinal anesthesia in the thoracic area is unfeasible. It's impossible. So I was quite scary at the beginning. But then, as you said, in the mid-thoracic area, the spinal cord it lies quite anteriorly, and there is room there, and it's not so impossible. I personally prefer to find the epidural space first with the loss of resistance, and then slightly advance the spinal needle. That guy, Dr. Starnari in Italy, he doesn't do it. It just simply goes in millimeters after millimeters and find the space.
Can I make a point?
Yeah, please.
How you give this anesthetic is not that important. There's a million ways to do it. What's important is how do you manage the analgesia in the first 72 hours post-op. I'm not sure I'd be comfortable with a spinal catheter for 72 hours, maybe going to the ward. That's just a personal thought.
Yeah, I totally agree. And I think it really depends on the organization of the center. It was in a relatively small center without ICU. And so it was basically able to involve the nurses and the physician of the ward. I wouldn't be, in my hospital, I wouldn't be comfortable at all to send an intrathecal catheter on the ward. I totally agree with you. Even because we were used to do many epidurals. And so if anybody pushes any medication thinking that is an epidural catheter, for example, that would be literally a disaster. But in that specific center, Dr. Starnari, he was able to involve everybody and to train them. And he left the catheters 72 hours usually post-op using levobupican in like 0.01% in continuous infusion.
I mean, I think this raises a great point, which is that, maybe no matter what kind of techniques you do, one of the problems with having to find solutions to extreme patients or cases is that that's perhaps not the time to start doing extreme, rarely performed interventions, because there's more than just the procedure that has to happen, right? And there are so many people that are part of the care, and familiarity, and they always say, you do what you do best. And then I think that's one of the challenges for us as our practices become sort of more narrow or prescriptive, is that we lose some skills, and then when we really need something outside the box, I don't know, it's hard to do. And we will be touched on that in the last part of this scenario, which is, the training issue. Just coming back to basic thoracic epidurals. Are our current generation of trainees getting enough experience, and how can we help people coming forward who don't have lots and lots of cases under their belt to be more confident in their techniques? But we'll move on to scenario 2. So Donogh, can you just walk us through it?
Yeah, sure.
And then the questions that come out of that.
So this follows on from scenario 1. So you are the attending anesthesiologist for the acute pain service, and the patient in scenario 1 had their operation performed with a thoracic epidural anesthesia and minimal sedation. So there's a 6 centimeter supraumbilical midline incision, and he's recovering in the ICU for monitoring purposes. And you've been consulted, as he had been doing very well overnight, but in the last 6 hours his pain scores have gone up quite a bit, and because of the pain his respiratory function is worsening, and he's requiring higher oxygen saturation, higher oxygen to maintain the saturations. So on examination, there's a lot of leakage of fluid around the epidural insertion site, and the bed sheets have already had to be changed. And when you look closely, the epidural has become dislodged from the initial 10 centimeter skin entry to 4 centimeter skin entry. So the main thing is really here what might have helped to prevent this secondary failure of the epidural, and then kind of secondarily what options you would consider to manage his ongoing pain requirements. Particularly, I'd be interested if people have any experience doing an audit of secondary failure in their institution, and if so, what kind of factors were uncovered.
Josh and Sharon, are you keeping your epidurals post-op?
Pardon? Oh yeah, yes, we are. So we have a few different options that, you know, Josh does a lot of audits. We should get him to audit and see if we've had any failures like this. So we either do the steri strips, which actually has been really effective. They've been using them at Sinai at least since I was a resident. So, you know, almost 10 years. And I think that, again, being practiced at a technique has minimized our like slippage of epidurals. And Josh and I have been also using the fixator device. I don't know if they're using it at other sites now. We've been using them actually for a lot of our peripheral nerve catheters, and we've had really good success with them. I don't think we've been using them consistently for our thoracic epidurals. I know that they use them at Michael Garron, and they've had very limited failure rates with that. But I think what's worked at Sinai so far has just been, you know, steri stripping the epidural till it can't be steri stripped anymore.
Yeah, the EpiGuard fixation device is pretty nice. I think they use it at TGH also, and it seems to kind of survive good, you know, 4 or 5 days. Oh, I see Peter's on. Peter, do you guys use the EpiGuard fixation device?
Yeah, yes, and I think perhaps the most important thing is to have a protocol and everybody doing the same thing, rather than 30 different things. And then if everybody's doing the same thing, then if you start to have failures, then you rethink it. I think that's the most important thing. But yes, we do use that fixation device.
What do you think about how far you should be threading the catheter in when you first place the epidural, and whether that has any impact on efficacy?
So I tried to perfect an epidural when I first started as staff, and I managed to pull it out. So then I'm like, why don't I just set myself up for success from the start? So I've actually encouraged the residents not to over-thread it, because I think when you start manipulating it and taking off the dressing, you risk infection, but you also risk, you know, the tape is there for a reason. So I'm actually, I give the patients really good education. I give their family good education, and I don't overthrow the catheter. I usually do it at 4 centimeters. I don't know what everybody else typically does, but I just find the less you manipulate it, the better your chances of it not becoming dislodged trying to fix it.
Yeah, I think the big problem is with high BMI, not this patient. So when we get a BMI 60 or 70, that's where, you know, of all the sweat and the folds and they're laboring. So those we do have a protocol. For those, I'll probably do some extra measures like, you know, the me-fix dressing, and you know, sometimes you really want to like just add an extra layer of like steri strips. Anything can really come off, but those are difficult epidurals, so to have them come out is even more frustrating because of the challenge of putting them in to begin with.
Can I ask, has anyone used tissue glue to help secure their epidurals? There was a study, I think, in a Japanese center last year, which seemed to have excellent results with it, but I don't know if anyone got experience using that more locally.
Has anybody tried tunneling the catheter?
I've seen Paul McCarty do it once or twice for a long-term epidural, like something that was going to stay in for a while, but not for like preventing epidural withdrawal. That's something we do more commonly, like dermal catheters and stuff.
I don't think we're going to do it routinely, but if somebody difficult to put in and the dislodging causes all kinds of problems, maybe something to consider. Because that's the old-fashioned way of making catheters stick.
I know that we had a very complicated osteosarcoma patient who our chronic pain guys were seeing. And I mean, it was a palliative procedure, and they tunneled it. So I guess it's also now the duration, like the purpose of the epidural was very different than the purpose of a acute pain perioperative catheter. So I know our chronic pain guys have done it, but that was very context specific.
Now, if you have an epidural that is not providing adequate analgesia when you round on them, what are some of the strategies that one could do to try and optimize that? Any particular dosing regimens that one might try? Any tests to do? Would you manipulate the catheter, etc.? Well, I guess if we talk about dosing, does anybody routinely now use intermittent bolusing versus a continuous infusion?
We do intermittent bolusing for all of our labor epidurals. So I think our institution and our pain nurses and like the staff are familiar with it. And I think Josh and I talked about this before. There's sometimes those epidurals and those patients that is the only way to make it functional. So our institution is already familiar with it and makes it easier. And then there are just some of those patients that just need the bolus to actually have good analgesic response to it. And we at least have our pump set up that, you know, if we needed to, we could do that.
Is there any reason you don't use it for all epidurals, even the non-labor ones?
I mean, the evidence is very good on obstetrical, and there's solid evidence. I don't know if there's the same, if it's looked at in the same way in a surgical population as it has been in an obstetrical population. I guess just more, you know, from doing training and where the standard of care is just usually routinely being doing the continuous infusion and then the boluses. But I think because our institution has used intermittent now pretty consistently for our OB population, I mean, I think that would be a good opportunity if anyone wanted to look at it for a surgical population, because I'm not aware of any evidence that shows that it's a better way of addressing analgesia for a surgical population.
Yeah, no, I agree. I don't think there's any good evidence right now that's published, which doesn't mean it doesn't work. It just means nobody's studied it and investigated it. But there, as you say, there are theoretical reasons, and if you extrapolate, I guess, from obstetrics, you might assume that it would probably work better.
And it does sometimes when you're struggling and you just try it and it does work, right? Just from like anecdotal evidence.
What kind of boluses and what kind of interval?
So, I mean, that's when you have to have a little bit more following of the patient. So usually when I do the intermittent bolus, it's anywhere between 5 to 7 I've typically done, depending on, you know, how patchy it is, what level it's put on. So I don't know if there's a recipe, because for the obstetrical ones, we routinely just put them in L3, L4, and there's a recipe there. There's a few more variables when you're dealing with the thoracic epidural. So I don't know if you can give a script to that, but you can see, like, that's where you just test the patient. I usually do 5 cc bolus and I see what their response is and I reevaluate, and then I decide how I want to proceed. I think like 45 minutes to an hour of the 5 to 7 cc, depending again on the level and the level of block you get, seems reasonable to me. I don't know, Josh, I know you've done it too a few times, if you have anything.
Yeah, for labor and delivery, the standard recipe is 10 mils. It's very dilute. It's 0.0625 every 40 minutes, but we can play around with it. If you need to raise your block, you cut it down to every 30 minutes. If they're very short, maybe every hour. For the most part, for thoracic epidurals, we run infusions. On a very rare occasion, I would come, if somebody needs a very high concentration, I would manually bolus 0.5% every few hours, which is very rare. But we haven't really programmed our pumps for thoracic epidurals to give PIB, which is a problem because we also want to run those for nerve blocks, and we still don't have PIB for nerve blocks, which is on Sharon and I's to-do list. But it takes forever to reprogram all the pumps and change all the hospital protocols. So hopefully we'll get to it at some point.
I have done a PIB for 1 or 2 patients on pain. I don't know, but it becomes labor intensive because you need to have the support staff, and it became a pet project of one of the APS nurses to follow up, to manage. So it becomes a resource management thing if you're starting something new. So that's why I'm like, maybe a good project for somebody.
Okay, let's move on then to the last bit of this, which is kind of talk about if we do have issues with success, and this can be sort of both primary failures and secondary failures. As staff in academic centers, I'd like to know what are the thoughts of people on how we should be doing thoracic epidurals, both to adequately train residents, but also with the recognition, I think that, thoracic epidurals particularly are a intervention that's being less and less practiced. So for example, should everybody be pushing towards teaching people to use things like the waveform analysis or the Tsui test, or even ultrasound, to just ways to try and make sure that when you do put your epidural in, you're more confident about where it gets placed. I mean, would everybody agree that the opportunities for thoracic epidural seem to be diminishing?
I mean, not at our site, but we have a very specific patient population at our site. So
do all your residents, though, get the chance to participate?
It's a very good question, Ki. We've had a varying level of seniority, juniorness of our residents. So I think that it depends on the resident. I mean, they get a lot of experience doing labor epidurals that by the end of their 4 months, they're actually quite skilled at them, and they have better tactile understanding of what it should feel like. I can say personally with the PGY ones, I'm less comfortable allowing them. I give them I do all the other stuff that we just talked about. I have them start the epidural. I usually finish it because I need to know that I have that tactile sense, and I make them touch and feel so that they know this is what going off bone, get off the bone here. We do the ultrasound, we do the Tsui test, we do the waveform analysis to at least get them exposure. But when you're dealing with a PGY1 who's just starting to get these skills, it's patient care still. I think the first and foremost, it's also about ensuring that the patient is going to be well cared for in their surgery.
Peter, what would you say, has the practice changed at all in the time that you've been at TG? Would you say that there is less epidurals being done compared to previously?
It's changed tremendously. 20 years ago, just in thoracic, in 2 ORs every day, over a week, we'd probably put in between 10 and 20 thoracic epidurals. Now it's probably 2 or 3 a week in the whole service, the whole thoracic service. So it's 10% of what it used to be. I really hate to be so negative about this. It's largely because we're doing so much thoracoscopy. But I think for us in thoracic, it's probably going to become that eventually we're going to have to ask the pain service to put in all our thoracic epidurals. I know that's kind of disheartening, but that's kind of the future as I see it in thoracic.
I mean, that ties in nicely because Josh published that paper where you demonstrated in Sunnybrook the introduction of a block room. And I presume by extension that meant epidurals done by a select group of people rather than a larger group. And that translated into a much higher success rate.
Right. So it was a limited paper in the sense it was retrospective. So it was hard to know exactly why the success rate was higher, but what we could find was when there was a problem, when there were multiple attempts, you would see a second experienced practitioner was called in. So somebody senior like Jonathan Kahn, like Paul McCarty, like Stephen Choi, and they were more readily available. Whereas if you're in an OR by yourself and you're struggling with an epidural, it's sometimes when everybody else is starting their first case of the day, it's not as easy. And the other part, actually, the percentage of trainees that were doing it wasn't significantly reduced. So it's not like we increased our success rate but compromised on teaching, which I thought was important. So the other factor that I thought translated was the use of ultrasound, which wasn't statistically significant, but you could see that for the difficult ones, anecdotally, Paul would use an ultrasound, and I've started using ultrasound for all my thoracic epidurals, and I think Sharon does as well. It's also a good tool for teaching to show the learner the difference where how the lamina looks and why it's a thinner kind of needle path. You got a smaller needle path, and already you can show it in the paravertebral space and the rectus spina, you know. So I think ultrasound is a very good tool that does translate to increased success. There was one study that tried to use ultrasound to decrease, their main outcome was time to insertion, which I don't think would be the right outcome. The right outcome would be, you know, success rate. It just wasn't powered for that, because epidural failures, you know, they're common, but not that common. So yeah, I think that was kind of the main point of that study.
Thanks, Josh. I mean, Peter, am I right that I was inferring from your comment about the pain service placing them that you think that the epidurals that are being placed are not as, or that the failure rate has gone up as well?
Oh no. And right now we do not get the pain service to place our epidurals. We still place them in the operating room just before the start of the case, as we've done for, I guess, 25 years. That hasn't changed. But I think with time pressure and lack of familiarity of some of the staff with thoracic epidurals, that I just foresee that it could be that we will just have to get pain service to do it in a block room outside of the main OR before the start of the case.
Well, we used to use quite a bit of thoracic epidural for bowel surgery. In fact, it's in the ERAS protocol. But the problem is so busy now, we hardly do any because we just don't have space for them. But once in a while, we do have a patient that we think that will benefit a lot, and we do it in the room. Supposedly, the thoracic epidural also get bowel function returned faster. So that's another benefit apart from pain control.
Yeah, I think part of the problem is that these even though it's still in some of the ERS protocols, I think people are feeling that it is not really adding to enhanced recovery, given that there are all these other advances that are taking place in the other aspects of the perioperative care. So I think, you know, and that's part of the reason why, for example, at the Western, thoracic epidurals are no longer routine for any of the laparoscopic colorectal stuff that we do. It just doesn't seem to be a benefit there. But I agree. I mean, I think there are always these logistical issues that need to be considered in addition to trying to decide what's best for the patient. Well, did anybody have any other comments that they wanted to raise or talk about before we bring this to a close?
The other thing that I don't know whether people still use TENS, the electrical stimulation. For a guy like this, you want to preserve thoracic muscle strength. TENS may be something to consider. Used to do it for all kinds of abdominal surgery.
Can you elaborate a bit, Jacob? Because I certainly don't know what that is.
Transcutaneous electrical nerve stimulation that you can use for abdominal surgery.
Is that to provide an analgesia?
Yeah, analgesia. Yeah. I used to work with a vascular surgeon that does a lot of abdominal aneurysm repair, and they routinely use TENS. It's still on the market. You can buy it. It's basically putting some electrodes around and just stimulate. So for somebody that you're worrying about, you know, thoracic epidural causing muscle weakness, etc., this is something to try. It seems to work for him.
You know, I want to say one thing, Ki-Jinn, about the fascial block, like ESP blocks. I anecdotally find that for chronic pain patients, it doesn't move the dial as much as for non-opioid naive, non-chronic pain patients. And for those chronic pain patients, you really do need a thoracic epidural, you know, the Suboxone, the fentanyl patch, the ones where, you know, opioid, they're just not going to touch. What's been your experience with ESP blocks for those type of patients?
Well, I don't know that I have enough to be able to say, oh, you know, opioid dependent, opioid naive patients respond better or worse. But I think in principle, you're always going to get a more intense block, a more reliable block, the closer you put the local anesthetic to where you actually want it to work. So I think a well-placed thoracic epidural is, you're getting it right there into the epidural space, close to the spinal nerves. And so it stands to reason that your analgesia is probably going to be more effective. So I think what you're observing is not, it's not unexpected. And so I think that's why, in a way, sometimes this move towards less invasive procedures, there'll come a point where it's a bit counterproductive, because when we really need something that works, now there's nobody who knows how to do it or is confident enough in the technique.
Okay, can I just highlight one other thing too? I think in this last scenario where, we've mentioned it already, but just to explicitly state it, one of the things that I like doing, especially with the junior trainees, and I actually routinely do, is doing ultrasounds for the thoracic epidurals. And as Josh mentioned before, it just gives you the most favorable site and conditions, because when an epidural goes in easily and smoothly, it usually works better than the ones you struggle with, and theirs are the ones that are patchy and they just never give you as good of a quality block. So I think one of the things in your comment of like, what can we do differently or better, is that I now again routinely use like a quick ultrasound, even if it's not like an in-depth, like let me look at the depth, let me count the spaces, which I do sometimes, but it's also just a quick scan, like which site and which level looks the most favorable, because that's going to be the easiest, and usually they work the best.
And when you say less favorable, are you looking at things like the interlaminar space, how wide that is?
I'm looking at the interlaminar space. I'm looking at the level of the transverse processes to see if there's any kind of scoliosis or just sort of anatomical changes. I'm scanning also, like I find as well, like some kind of extra information is also just the paraspinals in that area. Like someone who is already having some sort of anatomical shift, like it's all about symmetry. Like a space that is symmetrical and has a good interlaminar space and has a good, where you can actually get it into the interlaminar space, a good opening, it'll go in easier and it works better. So I think one of the key things I always highlight to the residents is looking for that symmetry and looking for the biggest space.
Excellent. Thank you for that.
About 3 years ago, we did have a lot of epidural failure rates, and I think it was Josh Rucker who did an audit, and in the end, we just decided as a group that we're going to make it mandatory to test epidurals before induction of general anesthesia. It doesn't have to be waveform, so it could just be lidocaine, but some kind of test was to be documented, and that did decrease our failure rate. Doesn't mean we still don't have the odd patchy epidural or the one that's too hypotensive, but we really stopped having the ones where the patient's waking up screaming because the epidural that felt so good going in is in fact not in the epidural space. And I think especially in a site that does let trainees put in epidurals, but in any site really, like if you're exposing the patient to the risk, part of informed consent, should say that there's a significant failure rate unless you're really testing it aggressively, and that should lower your failure rate.
Thank you, Josh. Well, it's 5:40 now. I want to thank you all for participating and being here. I think it was a great session. Great to hear from people who are doing this day in and day out. So thank you particularly to Josh, Sharon, Peter for sharing your insights. And I hope you all found this valuable.
Can I just say, I think this is a wonderful idea, this video conference rounds. I've never been involved in anything like this. So congratulations to the organizers. And could I just also point out one idea that Josh has given me? I don't know if it happens to any of you, but sometimes I have to take over a big case, at the end of the day, and they assure me that the epidural was working, but then I'm not convinced it is. So I think maybe now I'll just connect it to my art line and check the waveform. Just an idea.
You can just use your CVP line and take an extra extension with us.
Okay, yeah, for that, yeah.
But just remember, Dr. Slinger, you can't have too much dampening. So like if you have a lot of dead space, then you might think it's failed. Like the shorter the,
okay.
There's a few technical things.
Well, I have to try.
We can show you. We can show you.
Oh, thank you.
All right. Take care, guys. Thank you. Thank you, Donna.
Thank you.
Thank you, everybody.